Good morning and welcome to the fifth meeting of the Health and Sport Committee in 2021. We began our meeting in private session this morning and now move to the public agenda items. We have received apologies today from Alex Cole-Hampton. Please can I ask all members and witnesses to ensure that mobile phones are on silent and all other notifications are turned off during the meeting. The second item on our agenda is subordinate legislation consideration of two made affirmative instruments relating to coronavirus and international travel, which are laid under Section 94(1) of the Public Health Scotland Act 2008. The Act states that such regulations are subject to the affirmative procedure, but Scottish ministers may make the regulations if they believe they need to be made urgently, in which case those emergency regulations must be laid before the Scottish Parliament, cease to have effect on the expiry of the period of 28 days beginning with the date in which the regulations were made, unless before the expiry of that period the regulations have been approved by a resolution of the Parliament. It is for the Health and Sport Committee to consider these instruments and report to Parliament accordingly, and we will have an evidence session on these instruments, the Cabinet Secretary for Transport, Infrastructure and Connectivity and his officials. Once we have asked all our questions, we will then move on to the formal debate on the motions. I will invite the Minister to introduce the motions and the instruments, but I welcome to the committee Michael Matheson, Cabinet Secretary for Transport, Infrastructure and Connectivity, accompanying Scottish Government officials, Craig Thompson, Border Measures Review Team Leader, David Pratt, Policy Lead, Health Performance and Delivery Team, and Peter Brown, Police Enforcement Liaison and Performance Team. Thank you for joining us today, Cabinet Secretary. We intend, with your agreement, given the nature of these regulations, to ask questions on both instruments in the same session and then to proceed to debate them together. Questions may be general in nature and a few will undoubtedly be specific to the terms of the individual instruments. Cabinet Secretary, can I invite you to introduce these regulations and make an opening statement? Cabinet Secretary.
Thank you, Convener, and good morning to everyone. Country changes in these regulations are all related to the variant of COVID-19 that's been identified in South Africa. 4 more countries, African nations, have been added: the Democratic Republic of Congo, Tanzania, Burundi and Rwanda, assessed by the Joint Biosecurity Centre as at risk of probable transmission of this new variant. The United Arab Emirates was also made subject to the additional restrictions on the high-risk countries. This is because cases of the South African variant have been identified in England with a travel history in the UAE, but not in Africa. The implication, therefore, is that they have become infected with this new variant while in the UAE. The regulations also restrict passengers flights coming in from the United Arab Emirates, and there are also several other technical changes and clarifications relating to the passenger locator form, pre-departure testing and definitions of aircrew. And I'm more than happy to respond to any questions that members may have, Convener.
Thank you very much, Cabinet Secretary. Perhaps you could start, if you may, by indicating what your view is in relation to the South African variant and whether it is timeous to have put these provisions in place, and is it the government's view that that will prevent the spread of that variant in Scotland? Can I, before calling you to answer that question, can I ask my colleagues on the committee who wish to ask questions to enter an R in the chat box now? Cabinet Secretary.
So, Presiding Officer, sorry, Convener, the issues around the South African variant is that it's one of several variants that is causing concern, given the way in which it potentially can result in individuals who previously have had COVID, that they can be reinfected. So there are concerns about the implications it could have during the course of our vaccination programme. It became clear from the evidence that was provided by the Joint Biosecurity Centre that we had to move quickly in order to try and reduce the risk of the South African variant entering into the UK as a whole. And at that point, the decision was made to move to the red list system, where countries where it had been identified that they would be put onto the red list, which would ban flights, and any UK nationals returning from these areas would be required to self-isolate. Although that was the initial approach that was taken, it was clear also from the clinical advice which I received from our Chief Medical Officer that that would not be adequate in order to help to reduce the risk further of the introduction of this new variant, and that we would have to move to a form of managed quarantine for those who were coming in from countries which were considered to be high risk. That's why we agreed to moving towards using managed quarantine or managed isolation for those who were coming in from those what were rated red countries, risk countries. However, from the discussions which we've had with the CMO, it's clear that a system that is designed to respond to the identification of new variants is in itself a reactive system. And the only way we know where these variants are is because of genome sequencing, which is taking place within the given country itself. So we know about this from South Africa because they carry out a significant amount of genome sequencing. The problem that the JBC have highlighted and our Chief Medical Officers highlighted is that very often there will be mutations circulating that we are unaware of because of the lack of genome sequencing which is taking place internationally. And therefore, the way in which we can try to reduce the risk further around the introduction of a variant such as the South African variant is through a comprehensive system of managed isolation or managed quarantine. And that's why we made the decision, and the First Minister announced last week, that rather than just having managed isolation for those who are returning from what's classed as risk countries, that all international travellers arriving into Scotland will be required to use managed isolation. And in doing that, that can help to reduce the risk yet further. There are limitations, though, I would say to that, because clearly there is cross-border flow between England and Scotland. I've made representation to the UK government that we think that there should be managed quarantine for those right across the whole of the UK. They've taken a different view in that matter. However, we are taking forward a method and an approach in Scotland that we believe is the most robust approach that we can take in the present circumstances.
Thank you very much. I have questions from David Stewart, followed by Sandra White. David Stewart.
Thank you, Convener, and good morning to the Cabinet Secretary. Can I ask the Cabinet Secretary a wider strategic question? You may know, Cabinet Secretary, my interest in the development of an internationally recognised COVID digital passport, which has been raised by the Greek Prime Minister and is actively being considered in Europe, but it's been raised by the Tony Blair Institute and raised, and I have to say, a slightly ambiguous way in the UK Parliament. The idea, as the Cabinet Secretary will know, is that this, in the future, will get the economy back to work, will be recognised across the world, will be a big boost to tourism, and frankly will happen with or without politicians, in that companies like Qantas are already introducing this. I appreciate there's technical issues, I appreciate there are some issues around civil liberties, but if you look at the work that was done around the EHIC card, European Health Card, this can be done if there's a willingness to do it. And my final point, the Cabinet Secretary will be aware that the UK hosts the G7, a great opportunity to show leadership in this issue. What's the Cabinet Secretary's view in this? Has it been discussed in the Scottish Cabinet? Cabinet Secretary.
Good morning, Mr Stewart. I am aware of the issue around the idea of an electronic vaccine passport. I'm not persuaded that it's the right approach at the present moment. So given the challenges we have around new variants and our understanding of how the vaccine operates and the transmission of the virus, it doesn't feel to me at the present moment that the introduction of an international vaccine passport would be an appropriate alternative to the use of managed quarantine for individuals returning after international travel. However, I think at some point in the future it may have a role to play, but we are just not at that particular point as yet. I agree there are some civil liberties issues there as well. There can be good reason as to why someone is not taking the vaccine or the vaccines which are available, which have to be worked through. But it may be something that at some point in the future would have a role to play in helping to support international travel. But I don't believe now, at the present time, it is the way in which we can help to reduce the risk of the importation of new virus and new variants.
Convener, may I have a quick extra point on this? Thank you, Convener. I appreciate the Cabinet Secretary's honesty and openness about this particular issue. I would just make the wider point that this is not a zero-sum game. In other words, this could be an additional longer-term strategy. No one's suggesting this is an alternative to quarantine hotels. And the other issue in civil liberties, I was interested to find out that in America, where my son happens to live and work, where individuals have not gone ahead with the MMR vaccine, you know there were some issues around this, that basically what happened there was that nurseries and schools refused to accept young people who didn't have the vaccine. So it's, in a sense, it's a neutral issue. Whether people choose to have a vaccine or not, it's not for us today. I'm going to make the point there will be implications, there will be effects of that. So therefore, I see this as an additional long-term strategy, not as something an alternative to test and trace or quarantine hotels.
Cabinet Secretary.
So I agree with David Stewart on this matter. I think it could be one of a number of factors that could form part of a longer-term strategy in helping to support a return to international travel. The challenge will be identifying when we arrive at that particular point. And the reason I say that that's a challenge is because different countries will be at different points in their vaccination programme and also in suppressing the virus and how they go about achieving that. So I agree there is a need for international cooperation in introducing such a scheme, but we have to wait till we arrive at a point when we think it may be the right stage in which it can be introduced. So I think as part of a longer term strategy and a suite of measures that can be there to help to support international travel when it's safe to do so, it can have a part to play in that process.
Thank you.
Thank you. Sandra White to be followed by Emma Harper. Sandra White.
Thank you very much, Convener. Good morning, Cabinet Secretary. I wanted to ask some questions in regards to the quarantine and quarantine hotels, if that's what we want to call them. And I know what you've said in regards to the GBC highlighting the reduction, or trying to reduce the risk. I mean, in my mind, we should have locked down a lot earlier, on international travel anyway. But we're here at the moment, and I'm interested to note that whilst we here in Scotland are saying that now international travel via obviously Heathrow ever come up to Scotland, we're talking about having to isolate and quarantine in hotels. We're very disappointed that Westminster does not agree with that. What impact is that going to have on the travellers coming in via, say, Heathrow, etc., to Scotland? How will that be managed? And the third question I'd like to ask in that sector is, if monies, budgetary-wise, will the Scottish Government be responsible for paying for any quarantine hotels if Westminster is not jointly on board with what the Scottish Government wishes to do?
Cabinet Secretary.
So, good morning to Sandra White. Convener, you'll be aware as well, I'm making a statement to Parliament to set out some more details and the methods and the process we're taking forward with managed isolation over the course of the next week. What I can say to Sandra White is that I believe a UK comprehensive system is the safest and the most effective way to reduce the risk of the importation of new virus or variants into Scotland and the UK as a whole, and that is in all of our interest. The UK government have decided to take a different approach from us on this issue and only to target managed quarantine to those who come in from the red, the high-risk countries, while we'll be introducing it for all travellers who arrive into Scottish airports from an international destination. Clearly the challenge remains that for those who are arriving into English airports where they are travelling on to Scotland, that they, again, we're working with the UK government to see whether we can introduce a mechanism which would allow us to have these individuals carry out their managed quarantine at the point of entry into the UK, no matter where it is. However, we haven't been able to get agreement on that. So the system that we're putting in place is the most comprehensive that we can within the powers and the scope of our ability to do so. However, if that was applied at a UK level, it would make it even more effective. And that's why we're continuing to discuss and to ask the UK government to look at expanding their approach in order to capture a greater number of people who are coming into the UK overall. But you can be assured that we are taking forward an approach that we believe is the most effective means by which we can actually try to reduce the risk of importation of new virus and new variants into Scotland. On your point around costs, so the cost is borne by the traveller if they are making use of managed quarantine hotel or managed isolation at a fixed cost. We underwrite the hotel provision, so we block book the hotel facilities, which we are taking forward through a joint agreement with the UK government, so that there is one contract for all of these hotels, which has been taken forward on our behalf, which will block book hotels to the levels that we believe is necessary, and for those who then have to make use of it, they will then have to pay the daily rate that goes along with that. So part of that money is recovered from those who have to make use of the isolation hotels.
Thank you. Emma Harper, to be followed by Brian. Oh, sorry, Sandra. Yes, come back if you have a supplementary. Absolutely.
Yeah, I just want to apologise. My internet went down for the first couple of minutes. But just a follow-on question: how do we recognise? Do we ask the people who are coming on the flights? Do they fill in to say they're travelling on from Heathrow, for instance, to Scotland? How do we identify these travellers?
Cabinet Secretary.
So the information is, so someone who's coming in a flight into Scotland has to have completed a passenger locator form, which is a Home Office digital form that they collate, and they then pass on that information to Health Protection Scotland. So we get that information from the Home Office for individuals who have travelled from an international destination into Scotland. So we get that information directly from the Home Office, which then allows us to identify the individuals who are required to make use of managed isolation.
Thank you. Emma Harper, to be followed by Brian Whittle.
Thanks, Convener. Good morning, Cabinet Secretary. To pick up on what Sandra White said about managed quarantine, I have an interest in the internal flights or an ongoing travel, whether it is by air or even by ferry. So somebody coming in internationally to Dublin, for instance, and then ongoing through the port of Cairnryan into Scotland that way. So I appreciate that you're making a statement this week, but last summer we almost had zero transmission or zero COVID in Scotland, and I agree with Sandra White that maybe travel restrictions should have been put into place months ago to prevent people coming in. So how much pressure can you put on the UK government to basically show that the first stop from international arrival does need to be the place where the virus transmission can be really reduced for managed quarantine? Because that's a concern for me, because any ongoing travel does pose a risk for virus transmission.
Cabinet Secretary.
Well, I think you make a good point in relation to the risk of onward transmission, because the most effective means by which to deal with any quarantine arrangements is at the point of entry into the country, rather than waiting to them get to the end point, for the very reasons that you've outlined, and that is the risk of transmission as you travel, whichever means by which you travel, to get to your end point. So point of entry is clearly the best point at which it should take place. We've made representations to the UK government. I have a further meeting with them on Thursday where we'll cover some of these issues. There's a difference in our view around how it should be taken forward, but we'll continue that engagement with them and to explain why we believe that there should be a more comprehensive system across the whole of the UK, because we believe that's the most effective means by which we can deal with this issue. In relation to your point about someone travelling from within the common travel area, which includes the Republic of Ireland, we've raised the issue, as have the Welsh Government and also the Northern Irish Government, and also I believe the UK Government are now engaged with the Irish Government as well in this matter, around the issue of people moving around at different parts of the common travel area, because the COG report that looked at this issue and was published at the beginning of December highlights that a significant amount of virus importation into different parts of the common travel area came about through people moving between Scotland and England, or England and Scotland and elsewhere. So there is a need for us to continue to look at what further measures could be put in place to reduce that risk yet further. And one of the issues that we are keen to try and establish is a means by which we can try to help to reduce the need for people to travel around different parts of the UK. However, we're still some distance from getting agreement on what that would involve. But there is no doubt, given the evidence from the COG report, a need for progress to be made in this issue. And that's a point of discussion that we're continuing to pursue with the UK government, as all of the 4 nations within the UK recognise it as a point where action needs to be taken. The question at this moment is the method and the nature of the action that should be taken to try and address that issue.
Emma Harper.
Thank you for that answer, Cabinet Secretary. I'm just curious, just a final question. When we're talking about managed quarantine or quarantine hotels, what are we talking about as far as projected numbers? Is it tens or hundreds or thousands of people that are going to need to be put up in hotels?
Cabinet Secretary.
So I'm conscious, Convener, that I'm in danger of preempting my statement to Parliament this afternoon. So, but I would say that in terms of arrivals, there are 3 airports that are still receiving international arrivals in Scotland: Glasgow, Edinburgh and Aberdeen. Some are more associated with things like oil and gas, particularly in the Aberdeen side. So what I can say to the member is that we are working on a projection of numbers based upon the number of people who are travelling per week into Scotland through international travel. And what we are looking to do is to make sure that we have the availability for managed isolation for those who would need to actually undertake managed isolation. You'll be aware there are some individuals who would be exempt from it for particular purposes because of the critical nature of the role in certain sectors, for example, aircrew. So there are a level of exemptions to the scheme, but we are modelling a system which is based upon the number of individuals who are travelling into Scotland in any given week over the last couple of weeks, and to make sure that we have sufficient numbers of beds or rooms available for those who will have to complete managed isolation.
Brian Whittle.
Thank you, Convener. Good morning, Cabinet Secretary. It's just to follow on questioning from Sandra White there around the need to, or the Scottish Government's requirement that everybody isolates or goes into quarantine coming from international travel. And the question, of course, is that, as was raised just there by my colleague, around travel, onward travel from other destinations within an internal flight after an international flight. I just wanted to clarify, surely we have a system in place that tracks the origin of travel. We must be able to do that quite simply. And in that respect, then, when they arrive in Scotland, no matter where that the previous flight has come from, we should be able to identify them and ask them to quarantine. Is that reasonable?
Cabinet Secretary.
Good morning. The passenger locator form is the is the way in which we get that information, which the Home Office have put in place. So every traveller who's coming into the UK is required to complete a passenger locator form before they arrive, which sets out where they have travelled from, where they have travelled through, and where they are going to. So for someone who is transferring through on an international flight from Heathrow into Glasgow, we would have that information on that individual. However, my preferred system would be is for that person to carry out their managed isolation at their point of arrival, rather than then going on to a domestic flight in order to then have to complete their managed isolation, for the very obvious reasons. There's a risk that actually it creates in itself. And that's the point, one of the points of discussion which we're continuing to pursue with the UK government, is that we would prefer those individuals to complete their managed isolation at their point of arrival into the UK, rather than at the end point of their arrival, for the very reasons that I've just mentioned. So the PLF, Mr Whittle, is the form that provides us with that data and information on the individuals who will be required to carry out managed isolation.
If I could, just one quick follow-up, Mr Matheson. I understand what you're saying here, Cabinet Secretary, in that you prefer them to isolate in the place of entry into the United Kingdom. Is there and that there is a difference of approach. Is there any way in which, for instance, if that's what the Scottish Government want to do, they can insist that happens, and that they cannot board an internal flight following an international flight until such time as they've been quarantined? Is there any way that can be made into an insistence, if you like?
Cabinet Secretary.
So, just if it's helpful, Mr Whittle, as well, it is dependent upon the passenger providing the correct information on the PLF in the first place about where their endpoint is going to, and also then going on to an internal flight. If they come up by road or by bus, then they may not have completed the details of where their endpoint is. It may be their endpoint is London, but they're then travelling on, but don't provide that information. So there are some challenges within that system. To make it a requirement requires the UK government to take forward regulations to require travellers who will be looking to travel on to Scotland to require to complete their managed isolation at a hotel in England. So there would be a need for legal provision to be made by the UK government to facilitate that. And that's part of the discussion which we're having with them. In our view, is that they should be looking to put that in place. But we couldn't force it, Mr Whittle. It would be a matter that the UK government would have to agree to take forward, because it would require legislation put in place to make it a legal requirement.
Thank you, Convener.
Thank you very much. There are no further questions. I'm confident Michael Matheson will have enough new information this afternoon to satisfy the presiding officer in his statement. But we will now move on to the next items on the agenda, which are the formal debates on the made affirmative instruments on which we have just taken evidence. These are the Health Protection, Coronavirus, International Travel, Public Health Information and Pre-Departure Testing Scotland Amendment Regulations 2021 and the Health Protection, Coronavirus, International Travel, Prohibition on Travel from the United Arab Emirates, Scotland Amendment Regulations 2021. Are members content to a single debate being held to cover both of these instruments together? Members are content. We therefore will move on to the debate. We are no longer in question and answer mode, but I will invite the Cabinet Secretary to speak to and move the motions S5M 23953 and S5M 24066 in his own name. Cabinet Secretary.
Convener, given the discussion we've already had, I'll move straight to moving motion S5M 23953 and S5M 24066 in my name.
Thank you very much. Do any members wish to contribute to this debate? Brian Whittle, did you want to come back, or was that in relation to the question session?
No, I just want to, in terms of the debate, I think just wanted to highlight that given the discussion that we've had with the Cabinet Secretary and his straightforward way in which he's answered all the questions, it just raises again another issue around our inability, technically wise, which should be quite simple, is to track somebody coming into the UK and onward travel, and that's something, once again, from a technical perspective, we don't seem to be able to deal with. So that was my only point.
Thank you very much. There are no other members who have indicated they wish to contribute to the debate, so I invite Michael Matheson again to sum up and respond to the debate.
Convener, I recognise the concerns that Mr Whittle has raised, and that's why we need to continue to work with the Home Office defining the passenger locator form and how that information is shared with us. But it's a concern that we have, and it is part of our ongoing discussions with the UK Government. So I can assure the member that we will continue to try and identify ways in which we can improve the system and how it's operating at the present moment.
Thank you very much. Are members content that we put a single question? Members are content. So the question is that motions S5M 23953 and S5M 24066 be approved. Are we all agreed? We are agreed. Thank you very much. And that concludes discussion of these made affirmative instruments. Thank you. We now move on to the next item of our agenda, which is again consideration of subordinate legislation, this time a draft affirmative instrument, the Human Tissue Authorisation Specified Type B Procedure Scotland Regulations 2021. And for this item, I welcome to the committee Marie Goujon, Minister for Public Health and Sport, who is accompanied by Sharon Grant from the Health Protection Division and Caroline McIntosh from the Legal Directorate of the Scottish Government. Can I thank you for joining us today, and can I invite Marie Goujon to make a brief opening statement on this instrument. Minister.
Thank you, Convener, and thanks for the opportunity to make an opening statement, because I think it's important, and hopefully it'll be helpful to the committee if I set out the context in which the draft regulations have been laid. So I know the committee will be aware that the Human Tissue Authorisation Scotland Act 2019 introduces a statutory framework in relation to the authorisation and carrying out of medical procedures which facilitate transplantation, and these procedures are termed in the Act as pre-death procedures. They're defined in the Act as the medical procedures which might be carried out on a person for the purposes of ascertaining the suitability of an organ for donation or increasing the likelihood of successful transplantation after death. They're not for the purpose of safeguarding or promoting the physical or mental health of the person. Now, the committee will recall that in cases of donation following circulatory death, which is around 40% of deceased donors, these kinds of procedures must be carried out before the donor sadly dies. The framework for carrying out pre-death procedures is an important part of the new legislative regime around donation, and essentially provides transparency for the public about these kinds of procedures, which are already a necessary part of the donation process to ensure that the health and safety of organs for the transplant recipient. Now, turning to the regulations, the Parliament passed equivalent regulations for Type A procedures in March last year, and these are the procedures which are more routine, they're less invasive, and they're regularly carried out to facilitate transplantation. However, in some circumstances, if the clinical situation requires it, there are further diagnostic procedures which are available to clinicians to assess the health and safety of organs, and that could, for example, be if there's a possibility of malignancy which requires further investigation. So therefore, the Type B regulations which are now before you list the procedures which, unlike the Type A procedures, are not expected to be frequently carried out to facilitate transplantation, but which might sometimes be required as part of the donation process. Now, these procedures are not unusual in the wider context of patient care in the hospital setting. However, because of their non-routine nature in the context of transplantation and the fact that they are more invasive than Type A procedures, the Act permits additional safeguards to be set in secondary legislation, which must be met before a Type B procedure can be carried out, and I'll just briefly set those out. The regulations include a requirement that, unlike Type A procedures, which are authorised automatically by virtue of the donation itself being authorised, a Type B procedure must be explicitly authorised before it can go ahead. And given the circumstances in which donation takes place, where the patient will usually be unconscious in an intensive care unit, this authorisation will be sought from the patient's family. And further, in line with the approach taken in the 2019 Act, before giving that authorisation, the views of the potential donor must be taken into consideration so that such procedures are not carried out if they would be against the donor's known wishes. And as well as requiring that explicit authorisation, the regulations require that 2 conditions have to be met before a Type B procedure can be carried out. And they're further to the safeguarded conditions which are already set out in the 2019 Act. So firstly, the regulations state that a Type B procedure can only proceed if 2 doctors agree to the carrying out of the procedure, and that would involve them both considering that all the conditions set out in the Act have been met. Stakeholder feedback from the consultation requested that the regulations specifically exclude doctors involved in the transplantation process from performing that role, and that is now reflected in the regulations. And the regulations also require that one of the doctors must be the doctor responsible for the patient's care. These requirements reflect current practice around decision-making about a patient's care in relation to donation, and they provide certainty and transparency about the process. And the second condition, in order for the procedure to be carried out, the 2 doctors must also conclude that a lesser intervention, a Type A procedure, cannot be used to provide the necessary information for transplantation purposes. And that reflects the general approach to the carrying out of medical procedures and ensures that the minimum intervention is used to facilitate transplantation. So these additional conditions taken together with the requirements in the Act and the requirement for explicit authorisation really seek to ensure that in cases where it's necessary to carry out a Type B procedure so that an organ can be safely transplanted, there are appropriate safeguards in place to ensure that the interests of the donor are protected. And in practice, the requirements in the 2019 Act and the regulations mean that a Type B procedure will not go ahead without family involvement or authorisation, and that it will not go ahead prematurely or if it's not absolutely necessary to facilitate transplantation. In developing the regulations, we've of course worked closely with and taken the advice of clinicians who work in intensive care and across the donation and transplantation pathway. I'm really grateful for their input to help ensure that the specified procedures and additional requirements that we have are appropriate. And we've also consulted publicly, and the draft regulations before you take into account the responses to that consultation. So I'm happy to take questions now from the committee.
Thank you very much, Minister. The committee took a good deal of interest in this matter when the bill was before us 2 years ago, and can I invite members who wish to ask questions to put an R in the chat box in the usual way. And I see Sandra White to be followed by Emma Harper. Sandra White.
Thank you very much, Convener, and thank you very much, Minister. This is an issue, the Type B pre-death procedure, which I certainly did take a great deal of interest, as did members of the public also. Basically, not being a medical professional, it came as news to me, and I think the committee done a really good job of looking into the situation. I'm happy with what's been said by the Minister, and I just want to ask the additional conditions. That's something that we looked at in regards to doctors, and obviously the consultation to me was very important in regards to, patients, and the authority, the families, etc., etc. I just wonder, Convener and Minister, during the consultations, I know there were some religious groups who were still concerned. Do we have any people who were involved in the groups who were involved in the consultations who are still not happy with this particular procedure? As I say, I'm not moving against it. I think we've done a grand job in what we've done with consultation. If there were some people who still had misgivings in regards to this.
Minister.
I thank Sandra White for those questions. I mean, that's where the draft regulations that we've got in place, we did take into account a lot of the points that had been made in the process of consultation, and really just tried to make the whole process a lot more transparent. And as a result of some of the issues that came out in the consultation as well, that's where we have the extra conditions there about the registered medical practitioners that obviously need to authorise the Type B procedures, and also in regards to who those practitioners should be, as well as some other changes as a result of that too. I know that Sandra White mentioned about the religious element and some concerns around that too. That, of course, was taken into consideration throughout the consultation process as well. I don't know if officials might have more to add on that point.
Would Sharon Grant want to add anything on that point? Sharon Grant.
We did send a consultation specifically to faith groups. We didn't receive any responses, but maybe I could add to that. We've been carrying out, our implementation team have been carrying out a series of webinars with the help of Kidney Research UK. So we're probably on a weekly basis or a fortnightly basis carrying out webinars with Muslim, Sikh, Hindu faith groups and faith leaders to explain the content of the Act and also to explain what tests can take place. So far, I've got one actually after this meeting, but so far no one's asked any questions specifically on pre-death procedures. What might be helpful for the committee to know is that we've also got a mail drop going through the letterbox to every household in Scotland, which also goes into detail on the Type A and Type B procedures, so that the public in Scotland will be aware of the whole donation pathway.
Thank you very much.
Thank you, Convener. Thank you.
Emma Harper.
Convener, good morning, everybody, and good morning to the Minister. I think in your final, the final statement words that you used actually answered my question. But as a former liver transplant nurse myself, I know that there are many specialists involved in communicating with family members regarding pre-death procedures. And I guess my question is to look at the transplant specialists and the teams that are engaging with family members, especially minorities, as Sharon has just mentioned as well. It means that the specialists will be given adequate education to update them and in the specific provisions for Type A and Type B procedures. I'm sure that the clinicians are specialists and knowledgeable already, but I suppose, are they being given the support that they need in order to carry on their specialist jobs?
Minister.
Yes, a lot of training has been underway in relation to this as well. And I would say in particular in relation to the Type B procedures, they are very rare. It's rare that they would be used. And of course, because of the conditions that we have within the regulations, we need that explicit authorisation for the procedures to proceed anyway. But yes, I think that there has been, again, I don't know if officials will want to come in relation to this, but a lot of training has been done. And I know that NHSBT have ongoing training and additional support underway. There's also an e-learning tool as well, which I know that people have found really useful so far. So that is a process that has been ongoing and will continue.
Shannon Grant.
There's comprehensive training going on the whole Act, as well as the pre-death procedure framework, etc. So that clinicians have told us so far that they're really pleased with the training. We're also, most of the training is now, or all of the training is being done online. We're offering, and NHSBT and SNBTS are also offering additional training and support to any clinicians. And as the Minister has said, we developed an e-learning tool that the clinicians are really happy with, explains the processes, and that's something that they can use whenever they're not sure, and that will be accompanied by supporting guidance as well.
Thank you very much. That concludes. There are no further questions from members that I can see on this matter. We therefore move to agenda item 6, which is the formal debate on the affirmative SSI, in which we have just taken evidence, the human tissue authorisation specified Type B procedures, Scotland Regulations 2021. Again, as normal, this is a debate, and I will invite the Minister to move the motion, and if any members wish to contribute to the debate, they should enter an R in the chat box. indicate that. Minister, can I invite you to move the motion?
I'll formally move the motion, Convener.
That's fine. Thank you very much. That's motion S5M 23852, formally moved by the Minister. Are there any members who wish to contribute to the debate? It would appear not, and therefore, if the Minister has nothing further to add, we will then move to the question. The question is that motion S5M 23852 be approved. Are we all agreed? We are agreed. Thank you very much. And we will now move on to the 7th item on our agenda, which is again consideration of subordinate legislation, another draft affirmative instrument. And this one is the Civil Contingencies Act 2004, Amendment of List of Responders, Scotland Order 2021. I welcome again to the committee Marie Goujon, Minister for Public Health and Sport, on this occasion accompanied by Ian McAllister, Deputy Director, and Paula Richardson, Team Leader in the Mental Health and Social Care Directorate, and Carolyn McGill, Solicitor, Head of Social Care, NHS Workforce and Structures Unit. Welcome again, Minister, and welcome to your officials for this item. And again, can I invite the Minister to make a brief opening statement? Marie Goujon.
Thank you, Convener. As noted at your committee meeting on the 17th of June last year, health and social care partnerships are not currently designated as first or second responders within the Civil Contingencies Act, which governs the overall structure of the resilience programme for local, regional and Scottish resilience partnerships. So while Integration Joint Board Chief Officers have already been actively contributing to local emergency and resilience planning, including notably during the COVID-19 pandemic in areas like PPE hubs and in supporting those who are shielding, they have only formally done so through their roles as Directors of Health Boards and local authorities and without the appropriate reference to their accountable officer status within the Integration Joint Boards. So following that meeting in June of last year, the Cabinet Secretary for Health and Sport confirmed to the committee that, taking our recent experience of mobilising services to respond to COVID-19, it's recognised that IJBs should be included as responders in the Civil Contingencies Act, and that we would make arrangements for that change to be made in legislation. And we subsequently laid that SSI on the 18th of January. So as the committee will be aware, the Integration Joint Boards are responsible as a minimum for planning a significant proportion of the adult health and social care functions being delivered. Ensuring that IJBs are at the centre of emergency planning enables all bodies accountable for community health and social care services to be appropriately represented. By including IJBs as Category 1 responders, it ensures that where there is a risk of an emergency, including our ongoing pandemic response, which will impact the functions that are delegated to the IJB, there will be a formal, coordinated and appropriate arrangements in place for emergency planning, for information sharing and cooperation with other responders, as well as joined up information sharing and advice for the public. The amendment to the Act will therefore provide an overall structure for resilience planning that will ensure our health and social care partnerships are really built into that framework. Now, a consultation about including IJBs as Category 1 responders took place on Citizen Space between the 12th of October and the 22nd of November last year. And the purpose of that was to ensure that the inclusion of IJBs would have no significant wider impact or unintended consequences under the Equality Act, including the Fairer Scotland duty. An equality impact assessment was undertaken, as was a Fairer Scotland duty assessment. And in considering all of the responses to the consultation, Scottish ministers concluded that there are neither clear equality, operational nor strategic planning barriers to progressing the proposal and legislating for IJB inclusion within the Civil Contingencies Act as Category 1 responders. The inclusion of IJBs will ensure formal, coordinated and appropriate arrangements are in place for emergency planning to support local communities. You'll be aware that the Delegated Powers and Law Reform Committee considered the technical, legal and drafting points of the proposed change, and they didn't make any comments on the instrument. So again, I'd like to thank the committee for the opportunity to speak to this SSI today, and I'm happy to take any questions you may have.
Thank you very much, Minister. And can I invite any members who have questions to indicate with an R in the chat box? As you rightly say, we considered this in a meeting on the 17th of June, and we then wrote to the Cabinet Secretary on the 25th of June to seek confirmation that steps would be taken to alter the legal designation of health and social care partnerships. I take it, Minister, you would confirm that this measure meets in full the suggestions that the committee made to the Cabinet Secretary on the 25th of June last year. Minister.
Yes, that's right. And I know that there were some concerns that were raised through the consultation, but I think what's important to remember about this measure and these regulations is that they essentially formalise an arrangement that should be happening in practice. So it's not expected that there would be any additional burden to IJBs. I know that that was a concern that was raised. So again, it really just formalises that process and ensures that IJBs form part of any emergency response and are integral to that process.
Thank you very much, Minister. There are no further questions on this item. We therefore move to agenda item 8, which is the formal debate on the Civil Contingencies Act 2004 Amendment of List of Responders Scotland Order 2021, and can I invite the Minister to move motion S5M 23920.
Formally moved, Convener.
Minister. Thank you very much. Are there any members who wish to contribute to debate on this matter? If there are not, I will therefore put the question on the motion. Question is that motion S5M 23920 be approved. Are we all agreed? We are all agreed. Thank you very much. That concludes consideration of this instrument, and we will report to Parliament accordingly. And can I thank the Minister for attendance at both of those agenda in relation to both of those affirmative instruments. We now move to agenda item 9, which is consideration of the Scottish Government's budget for 2021-2022, for which I welcome to the committee Jean Freeman, Cabinet Secretary for Health and Sport, and Richard McCallum, Interim Director of Health, Finance and Governance of the Scottish Government. Thank you for joining us today. The committee published our pre-budget report. More than 50% of the Scottish budget. What are the expected outcomes from the Health and Social Care 2021-22 budget on the 10th of November. Last year, the timing and purpose of the report was to provide the Government with time to consider implementation of our recommendations in its forthcoming budget. The Scottish Government's response to our report was received, albeit only yesterday, clearly limiting how far members will have had the opportunity to consider it ahead of this meeting. Nonetheless, I'm sure the Cabinet Secretary will reflect on her response in introducing this agenda item, and I invite the Cabinet Secretary, therefore, to make an opening statement, after which we will move to questions. Cabinet Secretary.
Thank you very much, Convener, and I'm grateful for the opportunity to give evidence this morning on the budget proposals for our health and care services. The 2021-22 budget, as Ms Forbes said, is delivered in exceptional circumstances that require and have required an exceptional response. The budget provides funding to support our urgent work to control the virus and to protect our health and care services and the people of Scotland, whilst the vaccine is delivered as quickly and as safely as possible. It provides funding to remobilise and reform health and care services and to reduce health inequalities, which have been exacerbated by the pandemic. To deliver this, spending on health and care services will exceed £16 billion for the first time, with a further £869 million allocated to support the ongoing response to the pandemic. The funding settlement sees every penny of additional health resource consequentials passed on in full. We will ensure our frontline services continue to have the funding that they need to respond to the unprecedented and ongoing challenges presented by the virus, to remobilise and recover, and to redesign services. Funding for frontline NHS boards will increase by £316 million, that's 2.8%, building on our record level of frontline health spending in Scotland, which is currently £112 per person, 4.8% higher than that in England. We've also ensured that all NHS boards are within 0.8% of their target funding shares, the closest that all boards have been to parity since the formula was established. Our budget will deliver investment of £180 million to tackle waiting times, enabling boards to start to address the pandemic-induced backlog when it is safe to do so. and to improve access to hospital-based services. The Scottish Government will increase its package of investment in social care and integration by a further £72.6 million, underlining the commitment to support older people and people with long-term conditions and recognising the vital role that unpaid carers play. This takes the total package of investment in health and social care integration to £883 million and supports our ongoing commitment to move the balance of frontline spending to community health services. Primary care is central to our health and care service, of course, playing a critical role in promoting self-care and supporting management of long-term conditions. In 2021-22, we will invest over £1.9 billion in primary care. We will further increase our primary care fund from £195 million to £250 million, which includes support for the delivery of the new GP contract and for wider primary care reform to improve access and outcomes. We will increase direct investment in mental health services to £139 million, taking overall spending in mental health to over £1.1 billion. This funding will underpin our continued approach to improving mental health services and support for children, young people and adults, and will support the delivery of the Mental Health Transition and Recovery Plan, providing continued support for mental health assessment services and building on innovations and new service designs which have emerged in response to the pandemic. This includes the Clear Your Head campaign and continued expansion of digital services. We'll continue to invest in digital health and care, improving digital capabilities and digital access to care to drive collaboration and innovation and to support self-care and digital inclusion. This will include continued expansion of the Near Me video consulting service, which is now being offered to all public service organisations across Scotland. This budget further supports our work to tackle health inequalities and to protect those most at risk. One of the greatest health inequalities Scotland faces is the disproportionate harm caused by drug and alcohol in some communities. The budget provides funding of £145.3 million for alcohol and drug services, including £50 million targeted towards reducing drug deaths. This funding will be directed through a wide range of partners to focus on reducing harms, promote recovery and supporting our national mission to reduce drug deaths. In 21-22, the budget will continue to provide support to improve opportunities, participate, progress and achieve in sport and physical activity, to improve physical and mental health, well-being and resilience. We will also work with Sport Scotland to protect sport investment and will continue to underwrite potential shortfalls in lottery funding in line with previous years. In terms of capital investment in 2020-21 will increase by over £100 million to £529 million. This investment in our infrastructure will support the delivery of the Baird Family Hospital and the Anchor Centre in Aberdeen, as well as increasing elective capacity across Scotland to further support a reduction in waiting times. We will also provide additional resource funding to continue implementation of the Scottish Trauma Network. In conclusion, the Scottish Budget for 21-22 takes investment in health and care services to over £16 billion for the first time, recognising both the immediate and long-term effects of COVID on physical and mental well-being and on health inequalities. We will protect frontline services, continue to shift the balance of care towards community health services and continue to provide investment for direct interventions to address health inequalities. And I commend the budget to the committee. Thank you.
Thank you very much, Cabinet Secretary. Clearly, as you have said, there is significant additional funding relating to COVID-19 for the coming financial year, as we would expect. However, taking that aside, the increase in the health resource budget is broadly in line with the wider Scottish budget, where in recent years it's been slightly ahead. Is that a shift in priorities from the Scottish Government, or is it simply a balancing factor given the additional COVID funding going to the health budget? Cabinet Secretary.
Thanks very much, Convener. If you exclude COVID-19, the cash in cash terms, the increase to the overall Scottish Government block grant settlement is 2.9%. So we are not shifting our priorities. Health and resource consequentials have been passed on in full, and actually more with additional funding for drugs, the 30 million, which takes the total increase to 730 million. There are significant COVID consequentials, as you've rightly recognised, in addition to that, 869. So the overall priorities of government remain as in addition to other portfolios, to see significant investment in health, not only to respond to the demands of the current pandemic, but also, as I tried to indicate and may have the opportunity through the rest of the questioning to do, to recognise that there are a number of areas of continuing investment that have been initiated because of COVID but will need to continue, testing and vaccination clearly being two of those, but also that we need to invest in the remobilisation and recovery of our health service as we, I hope, move out of this pandemic in the months ahead.
Thank you very much. Clearly, the funding in the current financial year that was provided for COVID, the first part of that has been set out in some detail in the summer budget revision. However, there is still some detail, I think, to come, and in addition, not much detail in relation to the plans for the 869 million in COVID-related funding for the next financial year. Can you indicate what the priorities are for these allocations going forward, Cabinet Secretary?
I can. As I've said, testing and test and protect is overall how we would refer to it. Test and protect costs continue significantly throughout the coming financial year. Vaccination costs, I think that generally speaking, we all agree, whilst we do not yet know about the efficacy of the current vaccines in terms of transmission, I think the general expectation, and it is a sensible one, is that our annual vaccination programme will be significantly greater in the coming year and potentially the years thereafter than the flu vaccination programme. We don't know the scale and the size of that yet, we can't, but we need to ensure that we retain the capacity to invest in that infrastructure. NHS boards need to scale up or return to more normal working, we hope, as we move out of the current situation. That requires them to remobilise and consider how they will catch up in terms of the non-COVID health harms that are inevitably being undertaken. Social care support is another key element of the priorities for the use of that consequential funding. We've already, as you know, allocated funding in the current financial year in that area. We anticipate that we will continue to need to provide that support, and that includes additional PPE. As you know, we support social care with PPE, and we will continue to do that. That may change in terms of its overall cost depending on IPC guidance, but those savings are there, those areas of expenditure are there, and we need to recognise an expected underachievement of board savings. Given the many pressures on them, then I think we need to recognise that we anticipate an underachievement of board savings. All of that will be informed by the third iteration of board remobilisation plans, which I expect to receive by the end of this month. And we have specifically set out to look at remobilisation in terms of health and social care as one system, if you like, and those board plans will come to us by the end of February.
Thank you very much. I now call on David Stewart.
Convener, and thank you, Convener, and welcome, Cabinet Secretary and Mr McCallum. Cabinet Secretary, could you explain and describe how COVID-related funding for individual boards are made?
Cabinet Secretary.
I can do that briefly. Richard may want to add to some of the details, since it is very important work that he undertakes and oversees to make sure we do it well. So, as I said earlier, there have been, we're now waiting to receive our third board remobilisation plan. The initial one in April supported the immediate response. The second remobilisation plan at the end of July mapped out a forecast for the rest of the year. And the third remobilisation plan due at the end of this month will recognise anticipated costs for 21-22. They are subject to constant review and challenge, and we then look at actual additional costs and allocate the funds out on the basis of that. But Richard will be able to give you a bit more detail about how that process works.
Richard McCallum.
Yeah, I think really just 2 points to add to what the Cabinet Secretary said. So in terms of how that funding is allocated, we've taken an approach of a hybrid mix between a kind of formula allocation base and direct targeted funding. So where it's appropriate, where all boards have incurred similar levels of cost, in that instance we've allocated on a formula basis, but we know that in some instances there has been particular pressures or particular costs in individual systems, and where that's the case, we've allocated accordingly. We've worked closely with directors of finance throughout this. So in the initial wave, we were getting updates on a weekly basis to understand the full cost implications that they were incurring, so that we could undertake appropriate due diligence and governance at some pace. We've moved those kind of regular meetings back a bit to monthly. But that kind of detailed review with each board where we can assess, challenge and scrutinise costs has allowed us to allocate the funding as the Cabinet Secretary has laid out.
David Stewart.
Thank you. Thank both witnesses for their answer there. Could I ask a follow-up question then? What financial lessons have been learned through the course of the pandemic? For example, did you find then that there was a need for more central planning, as the governments are always alleged to want, or did you find that more devolution to boards in terms of decision making was what's required, or was it a mixture of both?
Cabinet Secretary.
Again, Richard may want to say a bit more of that, because we have throughout this conducted across all the areas of the health portfolio with boards and with integration authorities, as well as other key stakeholders, including our partners in local government, conducted an almost continuous lessons learned, some of which we are applying as we go. But I think it is a mixture of both. I think it is really important when you are delivering a national response to a national pandemic that you are really clear nationally what you expect boards to be doing and how they should operate. So if I think of something like the clinical prioritization framework, which I know Mr. Stewart will be familiar with, really clear, I know committee members understand this, that as you have to respond to more COVID cases coming in a finite resource in terms of our health service, in terms of beds and staffing and so on, you need to make decisions about what it is that you will slow down and what you will perhaps pause completely. We've been very clear that urgent trauma and cancer care needs to remain a priority throughout the pandemic, but in order to allow boards to make their own decisions and be flexible enough to do that in response to the varying levels of COVID demand that they were facing, but to ensure there was equity across the country of the approach, then the clinical prioritisation framework allows boards to work within that framework, prioritising those planned procedures in a particular way, knowing that what is classified as a P4 procedure in one part of the country is exactly the same classification in another. So the attempt to give flexibility so boards can make quick decisions in response to something like the pandemic, but also that there is equity for our patients across the whole country. There will be others, I know, other lessons in terms of overall financial planning and so on that Richard may want to touch on.
Richard McCallum.
Yeah, I think I would just add three things to what the Cabinet Secretary's said. The first thing, I think the real benefit that we found is the whole system approach. So where local systems have not just viewed additional funds from an acute perspective or a health board perspective, but also looked at it in the round of social care pressures, community care opportunities, taking that whole system approach, which really is what integration is all about. But I think we've actually seen that strengthened through the pandemic. So I think where there's a whole system approach, I think that's been a key thing in terms of funding. Going back to Mr. Stewart's last question, I think whilst allocations can be done on a formula basis up to a point, I think probably through the pandemic we've seen cases where NRAC isn't always the most appropriate approach. And I think there's maybe something about reviewing that and going back to NRAC and seeing if there are other options in terms of how we allocate. And I suppose thirdly, and I guess I would say this as a Director of Finance, but just the ongoing importance of governance. Yes, we've needed to make quick decisions and we've needed to be agile in what we have done, but nonetheless we've had to bear in mind the value for money implications as well at the same time. And I think holding that in balance with needing to make quick decisions, but at the same time always test out that value for money, I think that's come through as well through the pandemic.
David Stewart.
Thank you, Commissioner. My final question then is, what efficiencies have been identified as a result of the new way of working? Has this led to savings, or has this led to options in terms of funding areas such as social care?
So again, Richard may want to add to some of what I have to say. That there have been a number of efficiencies and improvements achieved. Examples of that would include staff working remotely, increased use of telephone and video appointments for patients where that is the right approach for clinicians to take. It is interesting, of course, just to touch on briefly, pre-pandemic, we did have the Near Me video consulting facility, primarily used actually in the Highland, and very little uptake elsewhere, now entirely across our health system and growing into other areas, entirely across our health system in primary care in many instances, but actually now a number of our specialist consultant colleagues looking to use it too for some of their outpatient facilities, and really good feedback from both the clinicians and the patients themselves. Of course, it has to be a clinical decision about whether or not face-to-face, because digital does not replace face-to-face. It's a bit early to say, actually, whether the position around quantifying savings. We will take a review of those areas across the sector in our planning process for 21-22, and we'll see some of that, I hope, come through from boards where they are wanting to embed new ways of working because of their clinical impact and their person-centeredness in terms of patients, but may also be producing efficiencies as well. But again, Richard may want to add to that.
Very briefly, before I call Richard McCallum, Cabinet Secretary, can you indicate, as part of this territory, whether the Scottish Government plans the continued use of community hubs? Cabinet Secretary.
Thank you. That is an interesting question. I think that whilst community hubs were an innovation, a very quick innovation, quickly set up innovation in response to the pandemic, and were the right thing to do, and our thanks are due to all of those, including primary care colleagues who worked so quickly to set those up within 3 weeks, actually. I think they and we can see a continued use for that type of approach in, if you like, a non-pandemic health system. And there is thinking going on at the moment about how the community hub approach, alongside the increase in out-of-hours coverage, minor injury units, the redesign of urgent care, which is underway, how all of that works together then to bring the right care as close to the patient as we possibly can.
Thank you. And Richard McCallum.
Yeah, I probably wouldn't add too much to what the Cabinet Secretary said. I think in some ways it is quite early to know the full extent of the benefits that we might have seen through the use of digital and things like the redesign of urgent care. One of the key things that we'll be picking up with health boards through the remobilisation plans that the Cabinet Secretary mentioned that are due at the end of February is to understand more from the boards what opportunities that they see in this space, and we'll be having those meetings with boards over the course of March to understand that in more detail.
Thank you very much. Thank you. I now call on Sandra White.
Thank you very much, Convener, and good morning, Cabinet Secretary and Mr McCallum also. I just wanted to ask a couple of questions in regard to the medium-term financial planning and commitments. So could I ask basically what impact the pandemic has had on the forecasts and assumptions set out in the medium-term health and social care financial framework?
Cabinet Secretary.
Well, I mean, to the end of 2019-20, the financial performance was broadly in line with the trajectories that we set out in the financial framework. It is still a bit too early to assess fully the impact of COVID-19 because, of course, we're still there, but we are expecting to see a greater shift in terms of services to the community, and the performance and financial assumptions that underpin the financial framework will need to be revisited in due course, and we have that in our sights.
Can I thank the Cabinet Secretary for... Thank you, Convener. I'm sorry about the video. I think the connection's not great here. Maybe it's good that you can't see me, I don't know. But I thank the Cabinet Secretary for that reply and understand, and I do thank you for the paper that you sent to us last night. Basically, I think I had some answers to my questions, which I've just replied to. My second and last question, Convener, is carrying on from that. When does the Scottish Government plan to publish its update on the medium-term health and social care financial framework?
Cabinet Secretary.
So again, Mr McCallum may want to say a bit more because this will be a significant piece of work that he will undertake. I think our position at the moment is that we will review this as we move out of this current pandemic, and it's very difficult at this point to confirm timings and absolutely make sure the committee is aware of that, of course. The financial and performance assumptions underpinning the framework, as I've said, will need to be revisited, but I do think I can say that there will be a further iteration. What I can't be certain about at this point is exactly when that might be, because it is in part determined by how swiftly we can move out of the current pandemic state.
Richard McCallum.
Yeah, I mean, there are a number of the kind of assumptions that we made in the financial framework the committee will be familiar with in terms of the levels of savings that we expected boards to make, about the shift to community spending of over 50% over the course of the Parliament. All of these things, I think, need to be reviewed and need to be revisited in view of what's happened in the last year, because I think it has, in some instances, accelerated some of that shift. And I think, as the Cabinet Secretary has said, I think it will take time for that to be bedded down over the course of the next year or so as we continue to work through the pandemic. But certainly from my perspective, we're very committed to doing an update of the financial framework, and would keep the committee updated in terms of our work on that.
Thank you very much.
Thank you, Convener.
Thank you, Ms. White. The Cabinet Secretary mentioned some of the highlights in the capital investment strategy. I wonder if there is a strategic document that will be published to set those out in more detail, and also whether there are any plans to use revenue financing to fund future capital investment in health facilities. Perhaps Richard McCallum, first of all.
Just on the question of the capital investment strategy, so the Cabinet Secretary for Finance last week published a an update of the infrastructure investment plan that informs the funding for all portfolios in terms of capital over the next few years. So that will inform the capital investment plans for the health and sport portfolio, and we'll be using that as the basis for our strategy and plans. In terms of the question about revenue financing models, so at the moment there are no plans to use revenue finance in any of the schemes or capital programs that we have underway and that were mentioned by the Cabinet Secretary at the start, in terms of the bed and anchor in Aberdeen and the elective centres. The mutual investment model, which is a revenue financing scheme, is something that the government is looking at as whether it's possible that this is something that could be used at some point in the future. But as I say, there's no plans at the moment for any current capital spend in health to use that model.
Thank you very much. Cabinet Secretary, I don't know if you wanted to add anything to that.
No, I think Mr McCallum's covered it.
Excellent. That's great. I'll then move on and call on Donald Cameron.
Thank you, and good morning, good afternoon even to the Cabinet Secretary and Mr McCallum. My questions are on NHS board budgets, and my first question is the NHS territorial boards appear to be receiving a much smaller cash increase than in recent years. It's 1.8% compared to 6.3% last year. I wonder if the Cabinet Secretary could explain why this lower increase this year.
Cabinet Secretary.
Thanks very much, and good afternoon to you too, Mr Cameron. I think it's important to say a number of things. First of all, the uplift is actually 2.8%. when you recognise the additional funding for primary care, mental health, trauma networks and drug policy. And of course, health boards have significant responsibility for all of these. So we can't think about health boards exclusively in terms of acute and hospital-based care, but to include all of that. So the uplift is 2.8%. Then there is the additional COVID funding. But the uplift does not take account of the Agenda for Change pay negotiations, which require to be undertaken as we move into 21-22 financial year. You'll know we're at year 3 now of a 3-year Agenda for Change pay deal. Affects a significant number of staff. We have very consciously said that Scottish Government will, in addition to the current board allocations, fund in full whatever the outcome of those negotiations are. So we need to recognise that that will be additional funding that will go to the boards. And the other point I'd make is that last year, about 3% of the uplift to boards was recognition of an increase in pension costs. That was a new spending demand, if you like, on boards, but it is now part of their recurrent funding. So it's now in the baseline, that additional 3%. So if you take all of that together, then you are looking at 2.8 against, broadly speaking, 3.3 last year. But this year, we have still to add in whatever the funding requirement is for the negotiated Agenda for Change pay deal.
Donald Cameron.
Thank you for that. Could I move on to ask about the three health boards which are currently receiving ongoing financial support, and to ask just a couple of sort of questions underneath that. Will these health boards require to repay this funding, and what's the general prospectus, I suppose, for these boards? Do you expect them to achieve a break-even position within the next 3 years, for example?
Cabinet Secretary.
So again, Mr McCallum may want to add to some of what I'm about to say. There won't be a requirement to repay any funding in 2021 received by a board. In terms of boards continuing to require in-year financial support and the likelihood of achieving a break-even position within 3 years. I do think it's still at this point, it's not where we would want to be, but it is too early to say. We need to revisit all of that through the remobilisation plans and the planned and the additional financial scrutiny that we'll be doing. We'll be clearer on that as we look to move out of the pandemic and see also what the boards are planning and how we scrutinise and challenge those and approve those in due course. And then we'll be able to understand more clearly the financial position of all of the boards and what we then think is a fair position to take with them and a fair expectation to have of them.
Richard McCallum.
Yes, so just to add, yes, in terms of 2020-21, there'll be no repayment of the funding that's been provided in this financial year, recognising that all boards have required significant additional funding for understandable reasons because of COVID. And as the Cabinet Secretary said, I think what we are keen to do now, working with those three boards, is just understand the full impact of what's happened over the last year, what that means to their trajectories. I think undoubtedly it will have an impact, and it will probably have an impact on all boards in terms of their financial plans. So that will be being picked up with them. It may take another year with the nature of the non-recurring funding that we've got from COVID to fully understand that, I think. But that's something that certainly we will be working with the boards closely on over the course of the next few months.
Donald Cameron.
Thank you, Convener. My final question is one that has already been touched on slightly in terms of answers to a question posed by David Stewart, and that's the long-term issue of NRAC funding and as the formula. Do you consider that NRAC remains the best way for allocating resources, given that a number of funding streams are not allocated on the basis of NRAC?
Cabinet Secretary.
Thank you. It is actually a really important question. I think I'm on record with this committee before saying that all formulas have their advantages and disadvantages, and it is pretty difficult, if potentially impossible, to reach a formula that is entirely fair and produces no disadvantages. All of that said, though, I think Mr Cameron has a really important point. I think the NRAC formula should be reviewed, partly in light of the pandemic, but also potentially in view of the review of adult social care, the report of which, of course, members will be aware from Derek Feely was published last week. So I think that as we look at the system in the round, Mr McCallum has touched on this, how the system has worked through the pandemic, how we are looking at the planning as we move forward into the next financial year. Underpinning that needs to be reconsideration of the basis on which you allocate funds and looking at that as a whole system approach as well. So I think the NRAC formula does need to be reviewed in the light of all of that, and perhaps a different formula or a different approach adopted as a consequence of the review. But at this point, I think it's the safest thing to say is, or the fairest thing to say is, yes, it should be reviewed.
Thank you, Cabinet Secretary. I think the boards which have received brokerage will be pleased by what they've heard today in the sense that I think Mr McCallum said there was an understanding of the pressures on all boards, and therefore there would be no pressure for repayment now, and process of achieving break-even will take time. I guess from the point of view of other boards, the question then might be, what incentive is there with your current approach for achieving balance, given that I think you could be described as taking a forgiving approach to those boards which have not achieved balance? What would your answer be to that proposition going forward, Cabinet Secretary?
Oh, Convener, I'm very rarely described as taking a forgiving approach, so I hope somebody's put that on the record. I think all boards understand that all of them will face difficult situations at different times, and the approach that should be taken is one that is, in overall terms, fair to the system. And I think that is the approach that we are taking. And we recognise that actually for all boards, not only those that you're particularly referencing, but for all boards, achieving savings in the current financial year has been an exceptionally difficult ask, not least because all of their resource and all of their energy has gone into responding to the pandemic. And that's not just about the number of cases and people in ICU, but it is about things like setting up community hubs and contributing to that, contributing to the testing and the vaccination programmes, all the vital things that had to be done. And I think as we go through, as we come to the end of this financial year, we look at the mobilisation plans for the next year, we have all those discussions. Into that mix will come, well, what is a reasonable expectation of overall board performance, and therefore of board performance of those particular boards that you referenced, and what time frame should we then be looking at. And of course, whatever conclusions we come to, a future Cabinet Secretary, I'm certain will make sure that a future Health and Sport Committee is fully apprised of that. But I think at this point, it's not possible to be more definitive than I am being at the moment, although I don't know if Mr McCallum wants to add anything to what I said.
Richard McCallum.
Yeah, just two things, I suppose. Firstly, just on the point about 2020-21, really we have just recognised it has been an exceptional year in terms of the additional funding pressures as well as many other pressures on boards. And so we've had to take that into account in terms of the expectations on savings and expectation on delivery of financial plans. And I think that it was right to do that. The second thing I would just add, though, is that there remains a statutory obligation for boards to break even, and it will. And so, just because we've had to recognise that the challenges of this year and potentially 21, 22, and beyond, there is still a responsibility that boards have to deliver financial plans that are achievable and can get them to the financial targets that they've set. So. We have to hold these things in balance, recognising the pressures there's been, but nonetheless, as we move on from the pandemic and over the next few years, there will need to be a focus, along with things in relation to service and quality. There will need to be that continued focus on financial management and control as well. I think that's important not to lose sight of in all of this as well.
Thank you very much, and I now call on George Adam.
Thank you, Convener, and good afternoon, Cabinet Secretary. I'd like to ask Cabinet Secretary about integration authorities, and in particular, there's always a challenge over set-aside budgets and how that works out for the integration authorities. You know, my first question would be, what steps are being taken to address the continued concerns with the operation of set-aside budgets for integration authorities? And my second question connected to that were, are there any lessons that can be learned from integration authorities that are actually doing well with set-aside budgets and they're operating effectively and efficiently?
Cabinet Secretary.
So thanks very much. So before the pandemic, there was quite a lot of work underway looking at the issues around set-aside budgets and the operation of those. Work was being carried out with individual partnerships where it was a particular issues, such as in Fife. All of that had to be slowed down, arguably halted for a number of months whilst people responded, including the partnerships, responded to the pandemic. And I think where we are now is, well, there's two factors, I think, that need to be thought of as we move into the next financial year. The first of those is, as I think Mr McCallum said earlier, and I completely agree, that the experience of the pandemic has seen significantly greater integrated working than on the ground, in practice, proper joint decision making understanding of the contribution that different parts of the health and social care system make and the value of each, significantly greater learning in the last year than we had managed to achieve before that. Now, it's unfortunate it takes a pandemic to do it, but what it takes is everyone having to point in the one direction and work together and resolve matters, reach decisions, make decisions about the appropriate use of funds and so on. Hold that for one moment and then recognise that we've now got the independent review of adult social care, which sets out a number of recommendations and challenges. And I think as we move into the next financial year, then we are likely to see a different set of funding arrangements for that integrated service than that we have been used to before. And that in and of itself may well resolve some of the issues around set aside and the difficulties that were experienced in some partnership areas, IJBs, but as Mr Adams says quite rightly, not in others. And we were using the lessons in those others to help us pre-pandemic with those that were experiencing more difficulty, a lot of it around, actually just around understanding different parts of the system. I think the system as a whole has moved on considerably in the course of the past year.
Thank you very much. George Adam.
Thank you, Convener. It's interesting, Cabinet Secretary, that you bring up the independent review in adult care in Scotland, because it recommended that integration authorities should, their budget should be determined centrally. But what do you think about that recommendation by the Cabinet Secretary?
Cabinet Secretary.
So what I think the Feely review did was look at what it thought needed to happen, as Derek Feely himself said, to get the practice of integration aligned with world-class legislation on integration. And what, if any, change had to be made, if you like, to the architecture around that. His conclusion is there should be a national care service. That national care service should be directly accountable to ministers, and ministers should be directly accountable for it. And the route of delivery that he identifies are integration joint boards. So that significantly alters their role, and therefore the resourcing goes direct to them. I completely understand the logic of his thinking. And as I've said already in response to the review, we welcome it. We welcome all the recommendations. The current government is content with all the recommendations, and as I suspect Mr Adams knows, I think a week today we have a debate in the Parliament, a government debate in the Parliament on the independent review. Of course, given the timing of all of this, next week we'll be in the middle of February, Parliament stops towards the end of March, there's an election, a Scottish parliamentary election, so a great deal of pick-up on the review will be for a future government. But there are some steps, I think, that we can take in advance of all of that that helps to lay the foundations for that national care service and for that particular person-centred approach that he's advocating.
George Adam.
No, thank you, Convener. That's my final question.
Thank you very much. I just wondered if Richard McCallum had anything to add to the points that the Cabinet Secretary has made in relation to integration authorities. Richard McCallum.
The only thing I would add, and it was more a point on set aside, was just there are a number of case studies in the response that came back to the committee that shows areas of good practice. There's updates from Lothian, from Grampian, and from Lanarkshire, as well as Dumfries and Galloway, and that sets out some of the improvements and changes there's been over the last year or so in terms of set aside work.
Thank you very much. And there was a supplementary question from Brian Whittle on this topic. Brian Whittle.
Thank you, Convener, and good afternoon, Cabinet Secretary and the rest of the panel. I was listening very, very carefully there around your answers to George Adam and the response of the IGBs to the pandemic, and I have to say that in my constituents reporting to me, I would suggest that the pandemic has raised significant issues around two different systems working without proper communication with each other. And I think that what I would like to highlight and ask Cabinet Secretary is, do you not agree that the pressures and sometimes incredible pressures that have been put on the IJB system and the integration of two systems has actually highlighted and given you the opportunity to understand where the real pressure points are and where the problems lie? And will the government take cognizance of that? And what will the government do to close those gaps within a system? Because I think we all agree that those working within the system have done an incredible job under incredible pressures, but the system itself and the IGB, the integration of the joint board hasn't worked as well as we'd hoped. And what lessons are there to be learned?
Cabinet Secretary.
So some, if not all, of Mr Whittle's constituents are also mine. I am, if I'm completely frank, struggling a little bit to answer his question because I'm not getting any specifics. Now, as a general answer, yes, in general, all systems should be reviewed, lessons should be learned, and where there are gaps, they should be filled. But the specific concerns that he is referencing, I don't know what they are until he tells me what they are.
Cabinet Secretary, yes, you do, because you've had these conversations several times, and the fact of the matter is, system in the NHS to look after those who are transitioning from home care to hospital care and back again has been extremely problematic. All I'm asking Cabinet Secretary is that these systems have to be reviewed because they're not working as well as you seem to be intimating there. And this is not a criticism of those working within the system. This is a fact that the system itself is not working as well as it should be after the amount of time that we've been working with IJBs. All I'm asking Cabinet Secretary is, will the government take cognizance of these issues and look to close the gaps?
Cabinet Secretary.
So that's very helpful. I disagree that it is the system that is not working, although all systems should always be improved and open to improvement. Actually, in many of our IJB areas, that whole process of providing support to people living independently in their own homes or in residential care, when they move into hospital, when they are discharged, that support also being realigned to suit what they need with them as the central part of the conversation. It does work well in some parts of our country and is therefore in some IJBs and partnerships. And in fact, the Feely report recognises that and uses some of those good examples, some of which are actually in a part of my own constituency. But that is not the case consistently across the country. And Mr Whittle is absolutely correct about that. And there has been work going on that for some time, continuing very much focused on those particular partnership areas and IJBs which are doing less well than others in that we would expect, where we are not seeing as forward planning an approach when someone is admitted to hospital for hospital care, forward planning to their discharge date and focusing on them as a person and what they then need to help them to continue to live as independently as they wish. So that work is underway, but it will be continued throughout the rest of this parliamentary term and undoubtedly will inform part of a future government's response to the Feely report.
Thank you very much, Cabinet Secretary. Cabinet Secretary, we may resume this evidence session on a future occasion if you're content with that. Clearly, we've been able to ask and get answers to many important questions. There are other areas I know members would wish to explore in some detail. So if you are content, I will conclude this question session for now, but invite you to return and to resume this session at a future date.
Of course.
Thank you very much. And in that case, I will now suspend this meeting and move into private session on a different platform. I suspend this meeting.